Good morning. Welcome again. Today we are going to see about the perineum. Okay, so the perineum is the part which is located between the two thighs. Okay, so what we are going to see, what are the important anatomical structures located in this region, the clinical importance. Okay, so that's the part which is between the thigh, okay, between the legs. Okay, so here you can see that the perineum, okay, can be divided into two parts. Okay, so uh, the diamond shaped, it's a diamond shaped structure. Okay, it's a diamond shaped structure. Just a moment. Yeah, so it's a diamond shaped structure. Okay, and it is the perineum can be divided into an upper part, which is called as the urogenital triangle, and the lower part, which is the anal triangle. Okay, the urogenital triangle is bounded by the pubic arch on both sides, pubic symphysis anteriorly, okay, and an imaginary line joining the two ischial tuberosities. Okay, the two ischial tuberosities. Okay, and on the anal triangle, it's anteriorly by this imaginary line joining the ischial tuberosities, the sacrotuberous ligament. Okay, at the sacrotuberous ligament on either sides. You can see that ligament. Okay, now the pelvis, it's if you see the pelvic cavity, we can divide the pelvic cavity into the main pelvic cavity and the perineum. Okay, so there are certain structures in the pelvis. Okay, and there is a layer of muscle which prevents the structures in the pelvis to descend down. Okay, say there is urinary bladder. Okay, so there is what else is there? Uterus, vagina, the rectum. Okay, so all these structures are there. Okay, and if such a big opening is there, so they can descend. Okay, but it's been prevented from descending down by the pelvic diaphragm. Okay, the pelvic diaphragm, it's formed mainly by these two muscles, levator ani and coccygeus. Okay, the levator ani and coccygeus. The levator ani, it's actually not a single muscle. It's actually made up of three muscles. Okay, several groups of muscles. So anteriorly, it is formed by a muscle. In male, it is the levator prostae, and in females, it is the sphincter vaginae. Okay, and a muscle which is present in the intermediate part, which is circling around the rectum, which is the puborectalis, okay, and pubococcygeus, and posteriorly it is the iliococcygeus. Okay, basically they prevent the abdominal structures and give strength to the abdomen, preventing the structures from descending down, and they are supplied by the pudendal nerve as well as from the fourth sacral nerve. Now let's see in this picture where are these muscles located. So this is pelvis, and this is the main cavity of the pelvis. Okay, this is the false pelvis, the outer part. Okay, and the part which is inside this pelvic brim. Okay, this pectinate line. Okay, iliopubic eminence. So this is the true pelvis. So below the true pelvis, you can see there are muscles, which is the levator ani, okay, and the coccygeus, which forms the pelvic diaphragm. Okay, so the levator ani. Okay, so this is the coccygeus. Okay, coccygeus muscle, which is going towards the coccygeus. Now, what are the muscles which constitute this one? So here you can see there will be one muscle. This is the female one. So here you can see the urethral opening, the vaginal opening, and then the rectum and the anal canal opening. Okay, so the first one is sphincter vaginae. So there will be a muscle which goes around this vagina. So that will be the sphincter vaginae. Okay, in males it's the levator prostae. Okay, then puborectalis. Okay, puborectalis, which goes around the rectum. Okay, and the pubococcygeus, which goes towards the coccyx, from the pubis towards the coccyx. Okay, so pubococcygeus. Okay, and lastly, ileococcygeus, from the ileum towards the coccyx, ileococcygeus. Okay, so these muscles constitute pubococcygeus, ileococcygeus, okay, puborectalis, sphincter vaginae, or levator prostae. So they constitute the levator ani. Why it's called the diaphragm? Because it covers the entire part, preventing, okay, similar to the diaphragm, which prevents the thorax and between the thorax and the abdomen. Okay, so it prevents the abdominal structures from descending down, and also it helps in increasing the intra-abdominal pressure. Okay, so what happens during when we increase the intra-abdominal pressure? Okay, so during maturation, defecation. Okay, so during those times, okay, it helps. Parturition. Parturition means delivery of the baby. Okay, the other muscle is the coccygeus. It is attached to the ischial spine and coccyx, and it assists the levator ani. Okay, so that's the coccygeus. Okay, it is arising from the ischial spine and it goes towards the coccyx, so that's why it's called as coccygeus. Okay, or some books call it as ischio-coccygeus. Okay, it assists the levator ani supplied by the fourth and the fifth sacral nerves. Okay, basically in the perineum, you need to know the the layers. Okay, so this has been partly covered in your anterior abdominal wall. So when I was covering the anterior abdominal wall, I was telling you regarding the layers. Okay, the superficial layer, the skin. Okay, of the anterior abdominal wall. Then the below it will be the superficial, sorry, fascia, and then the deep fascia. Okay, the deep fascia is not present in the abdomen. Okay, so it's been replaced by superficial fascia, which has got a fatty layer and a membranous layer. Okay, so here you can see the fatty layer. Okay, and the green colored part is the membranous layer. Okay, the fatty layer is continuous with the fat of the ischiorectal fossa. So here you can see the fatty layer is present, but around the genital region it is not present, the fatty layer, but it is once again present in the ischiorectal fossa. Okay, and the upper part of the thigh also it is present. Okay, in the genitals it is replaced by the dartos muscle. Okay, it is replaced by the dartos muscle, okay, which is present in the scrotum. Okay, you know this dartos muscle, it's the muscle which is responsible for the rugosity of the scrotum. Okay, rugosity of the scrotum. Okay, this along with the cremaster, they help in maintaining the temperature of the testes. Okay, so during the hot weathers, this dartos muscle it relaxes. Okay, and during the cold, they contract. Okay, so dartos muscle, which is nothing but from the fatty layer of the abdominal, fatty layer of the abdomen, it gets modified here as a dartos layer. Okay, this is only in males. Okay, in females there are no changes. Okay, then the membranous layer, the green colored layer you can see. Okay, so here you can see in the penis it gets modified into the buccal fascia, so then it descends on the scrotum. Now this is the part we are discussing, perineum, right? So this membranous layer is attached posteriorly. You can see that it is attached posteriorly to the posterior border of the urogenital diaphragm. Okay, so this is the urogenital diaphragm. Okay, so this is a urogenital diaphragm. So it is attached to the posterior border of the urogenital diaphragm and laterally to the pubic arch. Okay, so that you cannot see in this picture, you know, the pubic arch. Okay, so laterally it is attached to the pubic arch. Okay, and anteriorly it is continuous with the membranous layer of the anterior abdominal wall. Okay. This fascia is continued over the penis as a tubular sheath, penis or the clitoris. Okay, in scrotum or labia majora, it forms a distinct layer. Okay, it forms a distinct layer which is called as Colles fascia. okay, which is called as Colles fascia. Okay, so the membranous layer, it forms the Colles fascia, and then it gets attached to the posterior border of the urogenital diaphragm. Okay, now the superficial fascia of the thigh, the fatty layer extends into the thigh. Okay, but there is after this and continues down the lower limb without interruption. However, the membranous layer extends into the thigh and becomes attached to the deep fascia, okay, about a finger breadth below the inguinal ligament, okay, which is called as the Holden's line. Okay, it is called as the Holden's line. Okay, so this we have discussed it in the upper limb, lower limb, as well as in the GID, anterior abdominal wall. Okay, so that's the fatty layer or the campus fascia, the dartos muscle, the fat around the ischiorrectal fascia, the scarpa's fascia, Colles fascia. Okay. Now here you can see this is the superficial perineal pouch, and that's the urogenital diaphragm. That's the perineal body. Okay, and this is the Colles fascia. And the urogenital diaphragm, here you can see the superficial perineal pouch can communicate to the anterior abdominal wall. Okay, the superficial perineal pouch can communicate through the anterior abdominal wall. All right. Okay, now let's see the structures in the superficial perineal pouch in male. Okay, in male, the superficial perineal pouch. Okay, so here you will know that there is the superficial transverse perineal muscle. Okay, and also here you can see there is this muscle which is called as the bulbospongiosus and ischiocavernosus. Okay, the ischiocavernosus. Okay, so here you can see the superficial transverse perineal muscle, the external anal sphincter. Okay, external anal sphincter and the bulbospongiosus all are connected towards the perineal body. Okay, so as I said before, okay, the perineal body is nothing but like a contact place where all the muscles are joined together. Okay, so all the muscles are joined together at this point. Okay, and this point is called as a perineal body. Why this is important? Okay, this perineal body is quite important because once this is the one which provides strength to the pelvic diaphragm. Okay, so it's like a basin, okay, like a wash basin, the outlet, right? So that's the part here. This is the portion which provides the entire strength for the pelvic diaphragm. If this part is damaged, then the pelvic contents can descend through. Okay, so that's why this region is very important, the perineal body, which is the place where many muscles get united. Okay, so here you can see superficial transverse perineum, external anal sphincter, and the bulbospongiosus. Okay, all right, so this is a coronal section. So in this section you can see this is the superficial perineal pouch. Okay, this is the superficial perineal pouch, and this is the bulb of urethra. Okay, and that's the bulb of penis. Okay, this is covered by a muscle which is the bulbospongiosus muscles. Okay, that is the crus of penis, which is covered by the ischiocavernosus. Okay, the superficial perineal pouch, it is bounded below by the membranous layer of the superficial fascia and above by the urogenital diaphragm. Okay, so that's the superficial perineal pouch. It is closed behind by the fusion of its upper and lower walls. Laterally, it is closed by its attachment with the urogenital diaphragm. Here you can see that it is getting attached to the superficial, the membranous layer of the urogenital diaphragm and along the margins of the pubic arch. Anteriorly, it communicates with the anterior abdominal wall. So that's what we have seen in the first picture. Okay, so here you can see the boundaries of the superficial perineal pouch, anterior, posterior, okay, and it communicates with the anterior abdominal wall. Okay, all right. The next one, what are the other structures which are present in the deep perineal pouch? Okay, the deep perineal pouch. The deep perineal pouch is this one. Okay, that which is located between the superficial, uh, the superficial membrane, perineal membrane, and deep perineal membrane. Okay, so what are the structures which are present in the deep perineal pouch? In the deep perineal pouch, there is sphincter urethrae. Okay, there is a sphincter urethrae muscle. Okay, the sphincter urethrae muscle, dorsal nerve of the penis. Okay, the dorsal nerve of the penis. Okay, and it also contains the membranous part of the urethra. Okay, the membranous part of the urethra, the bulbourethral glands on either sides. Okay, the deep transverse perineal muscle. Okay, the deep transverse perineal muscle. Okay, so this is here there will be superficial transverse perineum, there will be the deep transverse perineal muscle. Okay, they lie parallel to the sphincter urethrae. Okay, the deep transverse and the internal pudendal artery. Okay, and the internal pudendal artery. Okay, so these are the structures which are present in the deep perineal pouch. We will see this here, the membranous urethra, the sphincter urethrae, okay, the bulbourethral gland. Okay, you can see the bulbourethral gland, though it is present on either side of the membranous urethra, they open into the which part? The bulbar urethra. Okay, they open into the bulbar urethra. They pierce through the superficial perineal membrane. Okay, this is the superficial perineal membrane, and this is the deep perineal membrane. Okay, so between the superficial and deep perineal membrane is the deep perineal pouch, and it contains sphincter urethrae, okay, bulbourethral gland, membranous urethra, the internal pudendal artery, okay, the artery to the bulb of penis, okay, and the artery to the crus of penis, which are branches from the pudendal artery, and the dorsal nerve of the penis. All right, so those are all the structures which are located in the deep perineal pouch. Okay, all right, now the body of the penis. Okay, in the body of the penis, it is made up of two corpus cavernosa. Okay, corpus cavernosa, they communicate with each other. Okay, and there is one single corpus spongiosum. So it has got two corpus cavernosa and one corpus spongiosum. The corpus spongiosum, it expands near the end of the penis to form what is called as the glans penis. Okay, to form what is called as the glans penis. Okay, the membranous part of the urethra passes through this corpus spongiosum. Okay, and this is called as the bulb of the penis. So it passes through the corpus spongiosum and then opens, okay, passes through the glans penis and opens into the external urethral meatus. Okay, external urethral meatus. Okay, so as I said before, these are supplied by the artery to the bulb of penis and dorsal artery of the penis, and the nerve supply is by pudendal nerve. Okay, the lymphatic drainage, okay, the skin of the penis drains into the medial group of superficial inguinal lymph nodes, whereas the deep part of the penis, okay, they drain into the internal iliac lymph nodes. Okay, so the skin, it drains into superficial inguinal lymph nodes, whereas the deep part of the penis, they drain into the internal iliac lymph nodes. Now, why this is important? Okay, the corpus cavernosum. The corpus cavernosum is the one which is, you can see why it is called cavernosum, because it has got a large number of venules in it. Okay, cavernous, capillary structures. Okay, so this is the one which is responsible for the erection of the penis. Okay, so here you can see the right crest and the left crest of the penis, and this is corpus cavernosum. Okay, so there are certain veins which pass through it. We have seen it here. Okay, so artery to the crest of penis. Okay, and veins we have seen. Okay, So that will be passing through this crust of the penis. Okay, and once this capillaries they get filled up, they help in maintaining the erection of the penis. Okay, whereas the corpus spongiosum, okay, so that is the tube which connects the urethra. Okay, the membranous, the after the membranous urethra, that is the penile urethra. Okay, the penile urethra. The end of this corpus spongiosum, it is enlarged to form the glans penis. Okay. Okay, now you know that there will be a skin which covers the entire part of the penis, which is near the tip of the penis. It's called as prepuce. Okay, the prepuce. Okay, and that's the surgery. What is the name of the surgery in which the prepuce is removed? Circumcision. Okay, so circumcision in which the prepuce is removed. Okay, all right. Now, why this lymphatic drainage is important? Suppose in case of carcinoma, okay, penile cancers. Okay, in penile cancer, we need to identify whether the cancer has it involved the deep structure of the penis. If it is only the skin of the penis, okay, you can remove the cancer, okay, as well as the superficial inguinal lymph nodes. Okay, suppose if the ulcer, okay, the cancer is deep and it penetrates through the fascia and then into the deep structure of the penis, then you might need to remove the internal iliac group of lymph nodes as well. Okay, so that's the importance of these two structures. Okay, any doubts until now? All right. The urogenital diaphragm, as I said before, the urogenital diaphragm, it is located between the two perineal membrane in the deep perineal pouch. Okay, so it is a gap between, and it is mainly formed by sphincter urethrae muscle as well as the deep transverse perineal muscles. Okay, between the superficial transverse perineal and deep perineal membranes. Okay, so this is the deep perineal pouch. Also, if you could remember, while I was talking about the anterior abdominal wall, I was discussing about what happens in case of urethral injury. Do you remember? In case of urethral injury, I told you if the membranous urethra is injured, okay, only the deep perineal pouch will be filled up. Okay, only the deep perineal pouch will be filled up. Okay, so the patient will complain of injury to the perineum and also he will complain on that he has not passed any urine. Okay, he will complain of severe abdominal pain and perineal pain. Okay, and history of not passed urine after the injury. Okay, all the other parts will be normal. Okay, why? Because if there is an injury to the membranous urethra during a perineal injury, the sphincter urethrae, they will close this, okay, and the urine will be leaked into this deep perineal pouch, okay, and it cannot expand beyond this deep perineal pouch. Okay, so it occludes the membranous urethra, and so the urinary bladder will be filled up. Okay, it will be filled up. Okay. Okay, the other one, if there is an injury to the superficial perineal pouch, urethra in the superficial perineal pouch, that is in the penile urethra. Okay, if there is an injury to the penile urethra, then the urine will be collected in the scrotum, penis, as well as the anterior abdominal wall. But it will not extend into the thigh because of the Holden's line. Okay, Holden's line. Okay, this we have already discussed. Okay, in the anterior abdominal wall. Okay. So this can be asked both in GIT as well as in GUT. Remember that. Okay, the urethra. All right, so this is just the same thing which I was telling about. Okay, anteriorly the two layers of the fascia, they fuse. Okay, and a small gap beneath the symphysis pubis here you can see. Okay, and they form the anterior transverse perineal ligament, and this is the posterior transverse perineal ligament. Okay, the two layers fuse with each other, and the membranous layer of the superficial fascia, and here the perineal body is also present. Okay, the perineal body, it is present here. Okay, So posterior, the anterior layer, the posterior part of the deep perineal pouch. Okay, the boundaries of it. Okay, now the urogenital diaphragm. So we have already seen that it's a triangular muscle filled with the sphincter urethrae muscle. Okay, and here you can see the perineal membrane, superficial perineal membrane, and deep perineal membrane. Okay, in between this is the external urethral sphincter, and parallel to it on the posterior side is the deep transverse perineal muscles. Okay, the deep transverse perineal muscle. Okay, so that's the perineal body, deep perineal pouch. Okay, now let's see next superficial perineal pouch in case of females. What are the structures? So here you are able to see the bulb of the vestibule. Okay, the bulb of the vestibule, which is covered by means of a muscle, which is the bulbospongiosus. Okay, bulbospongiosus, and the clitoris. Okay, the clitoris, which is similar to that of corpus penis. It also contains corpus cavernosum, and there are two crusts, the crust of the clitoris. Okay, and this crust of the clitoris is also covered by means of a muscle, which is the ischiocavernosus. Okay, uh, okay, which cover the crust of the clitoris, and this is the muscle which helps in the erection of the clitoris as well, similar to that of males. Okay, the ischiocavernosus in males, it helps in the erection of the penis because when they contract, they impede the flow of blood. Okay, and maintain the erection of the penis. Similarly, the ischiocavernosus in females, they help in the erection of the clitoris as well. Okay, and the perineal body. The perineal body, which is located between the vestibule and the anal opening. So this is the place. Okay, so here you can see what are all the muscles which are attached here in females. There is superficial transverse perineal muscles. Okay, and there is the muscle which is present around the bulb of vestibule, which is the bulbospongiosus. Okay, the bulbospongiosus, the external anal sphincter. Okay, so all these muscles are getting attached to the perineal body. Okay, the perineal body in males it's not that much important, but in females it's quite important because you know that in females they give birth to children. So what happens when they give birth to the children? Okay, so it has to come through the vaginal part, so this will be extended. Okay, so this will be extended, so it has to expand. Okay, and then she has to deliver the baby. Okay, and then it has to retract back to its original position. So especially in case of multiparous means females who give rise to many children. What happens, this perineal body might become weak. Okay, they might become weak, and when it is weak, what happens, the pelvic diaphragm will descend, and all the pelvic structures can come through the perineum. Okay, so that's what is called as uterine prolapse. Okay, you know that uterine prolapse. Okay, the other structures which are present in the urogenital triangle, so here you can see the clitoris. Okay, the roots of the clitoris, which is covered by ischiocavernosus. Okay, they also contain corpora cavernosa. Okay, the spongiosum is not present. Okay, in females. Okay, corpus spongiosum. Instead of corpus spongiosum only, there is the bulb of vestibule. Okay, the bulb of vestibules. Okay, in males, the corpus spongiosum is there because of the fusion of the urethral folds. Okay, in females, the urethral folds are not fused. Okay, so the bulb is separate. Okay, and they will form the end of but proximally what happens, this bulb of uh, the the bulb of the clitoris. Okay, so the corpus cavernosum near the end, so there will be an enlargement which is called as a glans. Okay, and that will also be covered by a small skin which is called as the prepuce. Okay, the lymphatic drainage is similar to that of male, superficial inguinal lymph nodes. If it is the skin, but deep means it involves the internal iliac group of lymph nodes. Okay, now the other structures which you need to know, especially in female, it is this the labia majora. Okay, the clitoris, the labia majora, and inner to it is the labia minora. Okay, the posterior part of the labia minora, they unite together to form a structure here in front of the external anal opening. This is called as fossa. Okay, it's called as fossa. So this is very important. Okay, this is also called as a gynecological perineum. Okay, gynecological perineum. Okay, why this is important? During the delivery of the baby, the midwife, okay, or the doctor, okay, so what they do is they protect or keep their hand towards the forehead. Okay, they support the forehead. Okay, so thereby preventing the tear of the perineum. Okay, otherwise what will happen if they don't support this area? This part, it keeps on expanding. Okay, and if there is a tear, the perineal tear, okay, the perineal tear can involve the anal canal as well. Okay, so that's why the protection of this foresheet is very important. Okay, the gynecological perineum, which is between this foresheet and the anal canal. Okay, so this part of the perineum is very important in females. Okay, it's called the gynecological perineum. Okay, this is the vestibule which is present between the labia minora. Okay, anteriorly there is clitoris. Okay, and in the inside the vestibule there is vaginal opening posteriorly and the urethral opening anteriorly. Okay, and near the end of this vaginal opening, there will be the opening of the greater vestibular glands. Okay, the greater vestibular gland, they will be opening near the end of the vagina, just before the vagina opens into the vestibule. Okay, the blood supply is by external and internal parental, and the nerve supply is by the genital branch of genitofemoral and the ilioinguinal nerves. The lymphatic drainage, it goes into the superficial group of inguinal lymph nodes. Okay, so these are the structures which you need to remember in case of female external genitalia. Okay, the deep the deep perineal pouch is almost the same, but there is no membranous urethra. Okay, so there is only one urethra which is present. Okay, and that's been protected by the sphincter urethrae. Okay, and posteriorly you can see the vaginal part. Okay, the posteriorly which is the vaginal part. Okay, they are supplied by the internal parental vessels. The urethra might have some ducts which is called as paraurethral glands. Okay, paraurethral glands. Okay, so vulva. So these are the structures you need to remember in the vulva. That's the mons pubis. Mons pubis is nothing but the part which is present in anterior to the pubic symphysis. Okay, so that is the mons pubis, labia majora, labia minora, what is vestibule, clitoris, the bulbs of vestibule, and the greater vestibular glands. You need to remember all these structures, okay, because they are important clinically also. Okay, the labia majora, so that resembles like the male scrotum. Okay, in male it is the male scrotum. Okay, on either sides. Okay, longitudinal elevations. They unite posteriorly and they form the gynecological perineum. Okay, the outer part of the labia majora, it is pigmented, whereas the inner part, it is rich in sebaceous glands. Okay, it is rich in sebaceous glands. So why should we know this? Sometimes skin infections can occur. Okay, so that's why you need to know. Okay, so that's it. And the round ligament is getting inserted into the labia majora. Now the labia minora, it's slightly inner side, and they correspond to the ventral surface of the penis. They do not have any fat. That's more important. If you see labia majora, they contain fat, whereas labia minora, they do not contain any fat. Okay, anteriorly they meet near the prepuce. They form the prepuce of the clitoris as well as the frenulum of the clitoris. Okay, and posteriorly they form the frenulum of the vestibule, which is also called as fossa. Okay, fossa. Okay, so this is very important, foreshead as well as the gynecological perineum. Vestibule, the part which is located inside. So here you can see the external urethral opening, the vagina, which has been Initially, there will be a covering which is called as a hymen, but later on it disappears. Okay. Clitoris, similar to that of males, it also has got a corpus cavernosa, okay, and is covered by ischium cavernosum, okay, and it helps in the erection of the clitoris, okay, and the bulbospongiosus, so near the anterior portion, it will not form corpus spongiosum, but the glans is found in the anterior part, which is the glans clitoris, okay, the bulbospongiosus covers the bulb of the vestibule. Okay, so now let's see some of the clinical conditions. So here you can see a female with a swelling in the labia minora. In the labia minora, what is this? So this could be because of a gland which is present just inside the vagina. What is that? Gartner's gland, greater vestibular gland. I told you the greater vestibular gland, right? So there you can see the greater vestibular gland. So the greater vestibular gland, okay, they open into the vagina, so that can lead on to a cyst which is called as Bartholin's cyst. Okay, Bartholin's cyst. Okay, so that one, and in case if there is a cyst, you need to make an incision and keep the gland open so that the secretions can come directly into the lower part of the vagina. Okay, the Bartholin's gland. Okay, so this is the, here you can see the Bartholin's gland opening into the lower part of the vagina. Okay, so they are mucous glands. They open below the hymen. Okay, below the hymen. Actually, if you see, the vagina does not have any glands. Okay, only in the lower part of the vagina there are Bartholin's glands or greater vestibular glands. Okay, the rest of the vagina, however, it is kept moist by the cervical secretions, which comes from the cervix. Okay, all right, so this is another one. Here it's a female who is in the labor ward. She's going to deliver a baby. Okay, the baby is in station +1. Okay, the diagnosis is CPD. What is CPD? Cephalopelvic disproportion. Okay, I will tell you what is it. Okay, so what happens is, okay, so imagine this to be the pelvis. Okay, so there will be ischial spine. Okay, the ischial spine. Okay, so depending on where the head is, the fetal head is, we classify it as, so if the baby's head is here, it is called a zero station. Okay, if it is above, +1, +2. If it is below, -1, -2. Okay, so this depends on the station in which the baby is present. Okay, and this is mainly to find out if there is any cephalopelvic disproportion. Cephalo means head of the baby, pelvis of the mother. Okay, if there is any disproportion. Okay, so what happens is, suppose if the pelvis is quite small, okay, the baby cannot come out through the vestibule. Okay, so that is called as cephalopelvic disproportion. Or in other ways, if the baby's head is quite large, there will be difficulty in engaging. Okay, the baby cannot come out. Okay, so this is called as cephalopelvic disproportion. So you need to diagnose this cephalopelvic disproportion early. Okay, even before the mother delivers. Okay, so you need to assess the pelvis. Okay, that's why they do frequent ultrasound, especially during the 38 weeks. Okay, there will be an ultrasound where they measure the head of the baby, as well as they check per vaginal to check if the pelvis is adequate and whether the baby's head can pass through the pelvis. Okay, if there is a disproportion, okay, then they might take in for C-section. Okay, so C-section. But suppose if it is engaged, okay, so suppose if it is engaged, sorry, this is minus 2. Okay, this is -2, -1, 0, +1, plus 2. I told the other way. Okay. Now here in this case, the baby is in plus 1 station. Okay, that is the baby started to come out. It has passed through the 0 and it is in plus 1, but it is unable to pass beyond it. Okay, so it is too late to take the child to the C-section, because you need to prepare for anesthesia, you need to call up the anesthetist, you need to prepare the patient. Okay, so that's why diagnosing CPD is important. But sometimes mild cases of CPD, it is quite difficult to find out. Okay, and in this case, the child might pass. Okay, the head might pass, but it might be obstructed. It's called as obstructed labor. Okay, so in those cases, what happens is we can we can deliver the baby using the forceps. Okay, we can use forceps or vacuum to pull the baby's head out. Okay, but what happens during this delivery of the baby's head? There can be injury to the female perineum. Okay, there could be a huge perineal tear. Okay, so imagine anteriorly there is the protection of pubic symphysis. So anteriorly nothing much can happen. Okay, posteriorly here only the coccyx is present. Okay, so when the baby is delivered, sometimes the entire perineum can be torn. So in order to prevent that, you can enlarge the vestibule. Okay, so what happens? The physician, they enlarge the vestibule. Okay, by giving a cut in the perineum. Okay, by giving a cut in the perineum. Okay, and this is a cut is called as, this procedure is called as episiotomy. Okay, usually it's a medial lateral cut. Okay, usually the cut is given in the medial lateral side, not medially. Okay, not medially. Why not medially? If you give a medial cut, then it can injure the anal opening. Okay, it can injure the anal opening. So after delivery, the mother will have severe pain even during defecation. All right, so that's why it is usual. It is avoided. You should not give any medial episiotomy. Median episiotomy. Okay, median episiotomy is should not be given. You should give medial-lateral. Okay, a medial-lateral incision is given. Okay, so that the pelvis is the vestibule is now quite bigger, and you can deliver the baby using a forceps or the vacuum. All right, so this is important. But when you are giving a cut, there will be pain, right? So there will be pain for the mother. So how are you going to make relieve the pain? So for which you need to give an anesthesia, which is called as pudendal block. Okay, the pudendal block. So what happens in the pudendal block? That is, the pudendal nerve is blocked. Okay, the pudendal nerve is blocked. But how do I know, like, where is this pudendal nerve? So for this, you need to do a pervaginal examination, and you need to palpate the ischial spine. Okay, you need to palpate the ischial spine. Then by means of a needle, okay, give the injection around the ischial spine, because the nerve comes out through this ischial spine. Okay, it's present around this ischial spine. Okay, so first palpate the ischial spine, and give the injection, the local anesthesia around the ischial spine. So that will block the pudendal nerve. Okay, and afterwards you can cut the perineum. Okay, give a mediolateral episiotomy. Okay, so this is called as pudendal block. Okay, so here you can see this is the ischial spine, and you can see the pudendal nerve. It is very close to the ischial spine. Okay, so if you give injection around this region, it will block this nerve. Okay, and you can make a cut in the vestibule. Okay, in the perineum, so that you can deliver the baby safely. After the baby is delivered, you can suture the perineum. Okay, you can suture the perineum. Okay, what happens if the perineum is not, if the episiotomy is not done? Okay, If the episiotomy is not done, okay, some mothers they will say like no need, I know you don't need episiotomy, let the baby come. So what happens? You need to explain it to them. What happens is if the baby delivers, because the mother pushes the baby out. Okay, so when the mother pushes the baby out, okay, so there could be a huge tear in the perineum. Okay, because there will be irregular tear. The gynecological perineum is quite important, as I said before, including the foresheet. It can tear in any direction. Okay, it can tear in any irregular direction. It can tear. Okay, if it tears laterally, it is okay. But if it tears median in the median plane, if it tears in the median plane, it involves the perineal body. Okay, you can see that it is involving the perineal body. And when the perineal body is involved, sometimes even the external anal sphincter is involved. Okay, and if the perineal body is injured, these muscles can be injured. Okay, bulbospongiosus, superficial transverse perineum, levator ani, and external anal sphincter. So this muscle, levator ani, this is one of the one which prevents uterine prolapse. Okay, uterine prolapse. Okay, external anal sphincter is the one which controls the fetus or the defecation. Okay, defecation. Okay, passing of stools. Okay, it is under voluntary control. You know that. Okay, so the external anal sphincter can be damaged. Okay, in a case of if we don't give episiotomy, okay, so it can damage this. All right, so that's why we give an episiotomy. Okay, so to prevent perineal injury to the perineal body, because many important muscles are coming at this point. Okay, okay, if the perineal body is injured, what will happen? As I said before, the pelvic contents might descend. Okay, if the bladder descends, it's called as cystocele. If the uterus descends, it's called as uterine prolapse. If the rectum descends, it's called as rectocele. Okay, cystocele, prolapse, okay, uterine prolapse, rectocele. So there are different degrees. Okay, first degree, second degree, there are different grades in which this uterine prolapse can be graded. Okay, that you will see in your clinics. Okay, so primarily this is to explain to you the importance of the perineal body. Okay, so the superficial perineal muscles once again is very important, especially in case of females. So that's the bulbospongiosus, the crus of clitoris, and the ischiocavernosus. Okay, that's the greater vestibular gland, which is opening just inside the labia minora. Okay, the lowermost part of the vagina. So this greater vestibular gland, when it has been blocked, that can lead on to the Bartner cyst. Okay, Gardner cyst or the Bartholin cyst. All right, this is the deep perineal pouch, sphincter urethrae. All right, and that's the end of today's session. Do you have any doubts?
Sir,
Yes.
what is the difference between prudental block and epidural anesthesia?
Yes, very good question. See, pudendal block is given only for natural birth. Okay, so during the perineal, before you make the episiotomy, it is being given. Yes. Before you make an episiotomy, you give a pudendal block. Okay, but okay, so before making episiotomy, that is to deliver the baby. But whereas epidural anesthesia is given in the spinal cord, not here, in the spinal cord, in the back. Okay, it is given in the back. Okay, the cervical, lumbar, sacrum, right? So here it is given. Okay, it is given here. So this what happens? Why the epidural analgesia is given? Because Nowadays, many people they prefer epidural anesthesia because that will reduce the labor pains as well. Okay, you know that the labor pains are quite severe. Okay, it is one of the highest painful thing. Okay, so each time that uterus contracts, there will be a severe pain for the mother. Okay, so in order to reduce that pain, they give the epidural anesthesia. Okay, so that will involve not only this part, but will also reduce the uterine pain, pain from the uterine contractions. Okay, some mothers prefer it, some mothers will not prefer it. Some mothers will say some mothers are quite tolerant. Okay, and they say like it's okay, I can undergo the pain. Okay, but some mothers either because they might be having some other conditions as well, so for which epidural anesthesia is preferred, or sometimes they might not be able to bear pain. Okay, so much pain, so this decreases the pain to a certain extent, not completely, to a certain extent. Epidural anesthesia. All right.
Thank you, sir. And also one more doubt: the foci, is it present on the labia minora or behind it?
It is behind the labia minora. That is, yes, so here you can see.
Okay.
Yeah, here. Just a second. Okay,
Yes,
so
sir.
this is the first one.
Okay.
Okay,
Yes, sir.
and this is
Thank
the
you.
gynecological perineum.
Okay, that's behind it. That's behind the
Yes,
foci.
that's behind the portion.
Okay.
All right.
Yes, sir. Thank you.
Any doubts? Okay, so with this we come to the end. Okay, if you have any doubts, you can just email me. All right. Thank you.